Hi, thank you for having me. I want to thank Surrey and the whole CFRI Foundation for asking me to come speak. This is my second time as CFRI conference. I was me and my coworker were both CFRI Professionals of the Year. We shared the honor in 2013, and I'm happy to be back. For those of you who don't, I know a lot of you out here, which is really nice to come speak to people I know. But again, I'm Cathy Chacon. I'm from National Jewish in Denver. Just a little bit about how I came onto CF. Back when I graduated from nursing school in 1996, there was a huge nursing shortage. I mean, there was not a nursing shortage. You couldn't get a job to save your life anywhere. So I was very lucky to get a job at the University Hospital in Denver. There was one job open in ortho and one job in pulmonary. And as a young 21-year-old nurse, I thought that ortho was really going to be the place to be. I was super excited, but unfortunately, she offered me the job in pulmonary, and I was like, sputum. Again, I was like, oh, I don't know if I can do it, but I was desperate for a job. So that, in 1996, I started working on the pulmonary floor. It was a brand new floor. It was specifically built for patients, all pulmonary patients, specifically for CF patients. That's when I fell in love with sputum, like Dr. Hoffman did. I fell in love with sputum. I fell in love with CF patients in 1996. And then my co-coordinator now, Sarah Brayshaw, a lot of you guys know her as well. She became the coordinator of the CF Center in 1999. And then in 2002, she asked me if I would join her. So we've been together strong for 15 years. As coordinators, well, her longer, me for 15 years at National Jewish. We take care of about 500 adult CF patients, so we stay very busy, and we're always getting more. And that's enough about me, so let's just get started. Oh, this seems to go really fast. Just a disclosure, I have been participants in Vertex, Chiesi, and Genentech advisory boards, and I am a speaker for Novartis. Oh, goodness gracious me. I'm sorry. I don't know why it's going so fast. Okay.
Are you good? And if this is easier,
I wonder if it is. Okay, I'll see how that works. Okay, so the objectives are to assess the healthcare challenges of our aging CF population, to consider routine health screenings and assessments for our patients as they age, and discuss a variety of issues, including gastrointestinal issues, women's health, nutritional and bone issues, CF-related diabetes, and mental health. This is kind of an offshoot of a talk that I did at the NACFC conference last year about health screenings, but it's with a lot more. And as you guys will notice, I don't hardly cover everything. I could probably stand up here and talk for 3 hours, but basically the goal of this presentation is to stimulate your mind to start thinking about some of these issues and how you can incorporate them into your practice, or if you're a patient with CF or a parent with CF, how you can incorporate them into your life. Okay. Oh, one back. I can't skip him. He's the cutest thing ever. So what is this? This is the face of CF, right? It actually is. It's the face of hope. This actually is a patient. He was diagnosed with CF when he was 73 years old. He had bronchiectasis. But this is something, we see patients like this all the time at National Jewish. I not only show you this because he's just adorable, but also to show you that we're going to be seeing a lot more of this in the future. My slide is a tidge outdated because the average age of survival is now 41, so that's exciting, but the overall idea is that the life expectancy has improved dramatically in the past in the past 10 years. And like Dr. Clancy said yesterday, over half of the CF population is now over the age of 18. So I'm going to get started right away in the gastrointestinal issues. This is a really hot topic as patients age, and there was some research that was done out of the University of Minnesota a few years back that looked at patients, 45 patients 40 years old and older who had both had transplants and who did not have transplants, and they all underwent colonoscopy screening. So what this study found was that there was a higher incidence of adenomatous polyps in these CF patients, and the incidence was higher in male patients, and that overall, while life expectancy increases, earlier colon cancer screening is warranted. There's still a lot of research going on in this area as patients get older. So the CF Foundation came out with a draft of some colorectal cancer screening recs that is not quite final yet, but I think is supposed to be final this year. But basically, the recommendation for non-transplanted CF patients is to have a colonoscopy screening done at the age of 40, and then reoccurring every 5 years unless polyps are found, and then rescreening is every 3 years or less if warranted. And what I mean by that is if the GI doctor finds polyps and is concerned about them, he may have patients do colonoscopies less than every 3 years. For transplanted patients, the same at age 40 or within 2 years of transplant, with rescreening occurring every 5 years. Again, the same if polyps are found, rescreening every 3 years if warranted. So the important thing with this is the bowel prep. And for CF patients, the bowel prep should be a lot more intensive than the average Joe. And what that means, I actually wanted to go over this because we spent a lot of time at our center looking over this to see what this means and what we needed to order. And this bowel prep regimen came out of the University of Minnesota. It's the one that they use. It's actually featured in CFRI's newsletter that just came out, that's in everybody's bags, the Minnesota colorectal screening guidelines. But just so you know, the bowel prep, we all know the mucus is much stickier in CF patients. It's very hard to get a clean bowel, and it takes a lot more prep than what some of us are used to. If you have been lucky enough to have a colonoscopy at this point in your life, you know that you usually drink 1 gallon of Go Lightly. It's a lot. It tastes terrible. Some GI doctors are even starting to use preps that have smaller volume, like New Lightly, but that's the opposite way that we want to go with CF. We want more. So, what this actually looks like is 3 to 4 washes of a liter each, and it's a split regimen. So if you look at the University of Minnesota recommendations, prep starts 3 days before colonoscopy, and it starts with a lower residue diet. And then day 2 before the colonoscopy, you'll drink a bottle of mag citrate. We fondly refer to that as the green dragon to help clear you out. The next day, you take 2 Dulcolax, so they just keep coming. And then day minus one, prior to the colonoscopy, starting at about, in the early afternoon, you drink 8 8-ounce glasses of Go Lightly. Then again, at night, that same night, 8 8-ounce glasses of Go Lightly. Then the morning of the colonoscopy, 8 8-ounce glasses. So if you count that out, that's almost 2 full liters of the terrible Go Lightly. It's really hard. We've been doing a lot in the hospital for patients who have GI concerns. We've been doing it as part of their hospitalization because some patients, it's really hard to tolerate. They get dehydrated. It could just be it's a little overwhelming, but it's a lot of bowel prep. But it's needed to get a good study. Moving on to some women's health issues, breast cancer screening. This is really a given. insufficient data on the breast cancer risk in CF, but this is a very easy test to order for patients. And considering that breast cancer is one of the leading causes of death of women, we just say all women over the age of 40 should get a mammogram. That's what's recommended by the American Cancer Society. And then some other specific women's health concerns include reoccurring vaginal infections. As you know, patients are on antibiotics all the time, so this is sometimes a problem that doesn't go away. It can be really annoying, life-changing for young women or older women. It is just a real nag. There's different medications you can use. Stress incontinence, specifically with women. Actually, I should go back and say fungal infections in men too. That's not only a women problem, but men can have reoccurring fungal infections as well. So stress incontinence, you heard Karen talk a lot about that in this morning's presentation. Irregular periods or abnormal periods, we hear this all the time from our women who are aging. We don't always know how to solve this problem, or a lot of these problems actually that I'm going to talk about. But because of the malnutrition, sometimes young girls with CF start puberty late, and then as you get older, women have really irregular periods, or period all the time, or no period at all. And then pregnancy, and I was going to slash contraception. My friends who were up here earlier are really studying that a lot. There's a lot to be studied with contraception. I think it's come to the forefront more now with the CFTR modulators and talking about appropriate contraception. Obviously, there's more research that needs to be done in this area, which I think is really up and coming. Word on the street is that some of the newer CFT modulators, you might not have to worry about contraception as much. And then pregnancy, just to touch on that a little bit with women. Like I said, we work with all adults. We welcome pregnancy. We talk to women about pregnancy when they're very young. It's a point we try to start talking about when people transition. There are a lot of things that women should know who have CF before getting pregnant. Any of you who have been pregnant and have CF know that it's not without risk, and that's an important thing to tell people. At some time in your pregnancy, you may be on oral and or IV antibiotics. There's limited antibiotics that we can use when you're pregnant, so I think it's really important to talk to patients about that before they go into something like that. We have not I know there's data out there that suggests women, it might be more difficult for women with CF to get pregnant. I don't know. I would say in our practice, we don't really see that as much. We have a lot of incidental pregnancies. So we see pregnancy a lot. I definitely say that there are some kind of loose FEV1 talks, requirements of different conversations we have with patients on pregnancy based on what their FEV1 is and their history of taking care of themselves. Pregnancy definitely seems to be harder on patients who have low FEV1, like low less than 30 or 40. But it also can be really hard on patients who have good FEV1 as well. And then we really try to educate these women on the postpartum period. There's been studies that show that CF women tend to decline after the postpartum period, not necessarily because of their CF per se, getting worse, but more the increased burden of taking care of a young child while taking care of yourself. For anyone who has kids, know that it's hard enough without having CF, but adding that burden as well is very hard for women, or can be. Okay, moving on to bones. This is a great slide that shows normal bone and then some Swiss cheese, osteoporotic bone. I would I would caution to say that this necessarily isn't an old age CF issue. We really, as providers, need to start thinking of it as at young age, because patients as young as 18 can have osteoporosis and osteopenia, and we need to start thinking about it early. So some of the nutritional and bone health issues that we see as adults age: osteopenia, osteoporosis, which can cause increase in bone fractures, which in Colorado, everyone likes to recreate. They like to climb mountains and then ski down them. And we see a lot of bone fractures and accident fractures in young people. The way that you test for bone issues is a DEXA scan. This should be repeated at the age of 18, or this should be done at the age of 18 and then repeated every 1 to 5 years depending on the findings. At our center, we work with a really dedicated dietitian and endocrinologist who are very in tune to bone density, so they help guide us on how frequently we should do these tests. So what if you have bone disease? Some of the things you can do, again, for any of you guys who work with a dietitian or see a dietitian at your center, this is like a dietitian's bread and butter. They absolutely love to talk about this kind of stuff. So what can you do? Vitamin D supplementation, calcium and vitamin K supplementation, starting a program where you do more weight-bearing exercise. And then we're using a lot more in adults, the anti-reabsorptive agents, the bisphosphonates like alendronate and Actonel. I say with caution because they can cause increased GERD and erosive esophagitis, which for patients who have GERD already can be a problem. Sometimes they're not well tolerated. And then our endocrinologist is using more Forteo and Prolia to stimulate bone growth in patients. And both of those are injections that can be given. So speaking of endocrinology, CF-related diabetes, another huge issue as adults age. We know it has a significant impact on respiratory disease, nutrition, and long-term outcomes. It occurs more frequently in females, but it also can occur at any age. And it's the most common comorbidity in CF patients, and it can occur up to 40 to 50% of the time. Again, at our center, and I think a lot of centers now have their own endocrinologists, or they refer to an endocrinologist that is very familiar with CF diabetes. I think that's key. If you're lucky enough to have one, I would use them as much as you can. So some of the screenings we do with CFRD to diagnose CFRD, many of you know, is the oral glucose tolerance test. It's a 2-hour test. It involves fasting overnight and then taking blood sugar levels from blood sample at fasting, half an hour after a 75-gram glucose load, and then 1 hour and 2 hours after. Also, we check hemoglobin A1Cs, although this is not diagnostic for CFRD. We still consider it part of our yearly lab profile in helping us look at the patient's glucose averages. We ask patients to do glucose logs if they may be on the cusp. And then we love us some food diaries. If you guys have nutritionists and an endocrinologist, they love food diaries too. And it's really fun to look at them. If you don't ever look at some of the patients' food diaries, it's just really fun. I mean, because you are like 17 pieces of bacon. I mean, sometimes it's like a dream list of what everyone wants to eat: 17 pieces of bacon, 3 lunches, a smoothie. It's really fun. I encourage you to look at food diaries if you never look at them, because it's a hoot. Some other CFRD screenings that are that our endocrinologist really presses patients for annual eye exams to check for retinopathy screen, hypertension, we do lipid screens, foot exam, and other yearly labs. Our endocrinologist does microalbumin yearly or more frequently with our CFRD patients. Okay, it's like a roller coaster ride. Moving on to mental health, which somebody was asking me earlier, what do I think is one of the biggest issues with adults with CF? And I would say this is probably, mental health is probably at the top of my list just because it's so involved in so many other things with CF. You know, we have so many patients who have a hard time doing treatments because of depression and anxiety, the way that people grew up with the average life expectancy only being 41. Many people who are adults now grew up thinking that they weren't going to live till adulthood, that they would never go to college, they would never have a job, they would never get married. And this has really affected the CF psyche and I think how patients take care of themselves. So 29 to 46% of CF adults suffer from depression. It's a significant risk factor for the effective management of CF. Individuals with CF and parent caregivers have increased risk of depression and anxiety compared to the general population. I would say CF spouses are included in that. And then the focus should be on prevention, screening, clinical assessment, and intervention. And this all came from the CF Foundation's mental health guidelines that that came out, I believe it was last year or the year before. So to go into this a little deeper, so prevention would include education, intervention, promoting disease management and coping skills, and using problem solving and cognitive behavioral therapy. So I think as providers, we need to educate people. It's all about education all the time. Walking patients through their care plan, reassessing care plans frequently. You know, you can't give somebody a care plan and then see them 1 year later and expect that same care plan to always stand because people are changing all the time. You have to plan for various stages in their life, whether it's a patient who's transitioning, who's 22 years old versus a 50-year-old who is just diagnosed. Education is not the same for both of those people, and you need to assess that and plan accordingly. Helping solve problems. It's kind of a ongoing joke that sometimes we feel like a life coach, like a professional life coach, because that's really what this is all about. You've got to help them solve problems. You got to figure out what stage they're in, and you have to use the whole team. Every team member has something different to add. I can't stress that enough. You'll hear me say it a million more times. Use your multidisciplinary team. We have patients who come in and they're depressed and they're anxious. They feel hopeless. They're not doing their therapies. One of the things we do when we see patients like this is bring in the respiratory therapist and really have the respiratory therapist go over every single piece of equipment and their whole treatment, you know, starting from when they get up, you know, until they finish. And you would be surprised at how, you know, changing up somebody's technique can change their life and make them want to do treatments more. You know, sometimes our respiratory therapist will have patients take a picture of like their actual setup. And I don't know that for some people it's very, you know, if their stuff's all a mess, they can't do it and then they just won't do it and then forget it. It's too late. You know, one day turns into 2 months and then forget it. But, you know, sometimes if the nurses or the respiratory therapist can help them organize like a station where they can do their treatments, the respiratory therapist can talk to them about things like using an a cappella or a flutter valve versus the vest, if that's appropriate. You know, there's lots of different vests now. I mean, this is all about trying to assess each patient individually and trying to figure out different things that'll work with them. So the next thing to do is screening. At our center, we were lucky enough to get a grant from the foundation for a psychologist, which has been fabulous because between our psychologists and our social workers, they are doing screening, PHQ-9 depression screening and the GAD-7 screening on virtually every single patient we see. You know, what we're finding is, unfortunately, there are very many patients who are anxious and depressed. So then they move on to the clinical assessment phase. If they're anxious or depressed, their screen is positive. This becomes the really tricky part. Part of the psychologist's job is to help us with assessment and referral. For those of you guys who work on the front lines, you know that in this day and age of healthcare, mental health, it can be very difficult sometimes. This process can be very difficult, the referral piece, because of insurance, because sometimes you can't find an appropriate psychologist or don't have an appropriate psychologist or psychiatrist to work with CF patients. It has to be somebody, you know, who understands how complex CF is and chronic illness is, and chronic illness in younger people and older people. And then we usually do a suicide risk assessment as well. And then the intervention would involve making a mental health care treatment plan. We really like to say this is two-prong, using psychological treatment and pharmacological intervention if needed. Again, a lot of people are looking for a quick fix. We really try to educate them that although medications can help, it's really a lot would depend on getting set up with a psychologist or a social worker and doing more cognitive behavioral therapy or talk therapy with them to help them change behaviors. And then this is kind of my wrap up screen. This is kind of like everything else. And there's this really great article that came out of my center. So I have to give props, although Dr. Dave Nichols is in Seattle now. This paper was written by him and my director, Jerry Nick, and our clinical pharmacist, Kelly Cook. And this kind of encompasses a whole picture of issues to think about as CF patients age. And it was published in Current Opinions in Pulmonary Medicine. I would encourage you to read the whole article because it brings up a lot of important points. But some of the ones that I wanted to touch on are as patients age, you have to start thinking about drug interactions and unexpected side effects from drugs that you commonly use. And so we know with the modulators, there's a lot of drug interactions that come along with them. More people are on modulators, which means for people who have things like mycobacteria and they're on medicine like rifampin, you have to consider that. People who have ABPA and who are on azoles, you have to consider that as well. Fluconazole, which we use like candy for vaginal infections or any fungal infections, you really have to start considering that. And then unexpected side effects from drugs we most commonly use. I mean, there's always been the thought that using enzymes over a long period of time might increase fibrosing colonoscopy. Now patients are living longer. That's something, you know, we need to start thinking about more. Using steroids, which we are always hesitant to use, but we do use, you know, as patients get older and you look at them in their 50s and 60s, you have to start thinking about the havoc that steroids are going to wreak on their bones. If patients also have diabetes, steroids also wreak havoc. And then consider treatment burden, the adjunctive therapies versus replacement of current therapies. I can't talk about, as an adult care provider, I cannot talk about treatment burden enough. You heard it in an earlier talk. The average adult spends 2 to 3 hours every day on their treatments. This includes doing their treatments, cleaning, sterilizing. I would venture to say there's even more hours spent taking care of their CF, doing things like preparing food, navigating the whole healthcare system, which for those of you who work, again, on the front lines, know, I don't think any of us appreciate how time consuming some of that stuff is. So I think 2 to 3 hours is kind of a soft number. And so we need to start thinking about that, because as patients get older, what do providers do? We think of more things that they can do. So you feel like this? Why don't you try increasing this? You have this problem? Why don't we give you something new for this? So, and unfortunately with CF, with the aerosolized medicines, a lot of it is time consuming. It's not just taking a pill and getting rid of the problem. We talk a lot about how if you really think about it, CF is one of the only diseases where the sicker you get, the more we physically ask you to do. I don't think people think about that in that context as much. If you have cancer or something like that, many times you take pills and you rest. Your doctor always wants you to rest. I mean, we want you to rest too, but we want you to do, 16 treatments and eat and exercise and do all these things. So, I mean, I just think that as people get older, we really need to think about that. Also, there's talk about replacement of current therapies. All of the studies that were done on modulators were done when people were on really good CF regimens. I don't think there's been any studies that show that we can start withdrawing those things, but possibly maybe somebody should think about doing some of these studies, because maybe withdrawing things, we know patients self-withdraw all the time, right? So maybe if there's some data that can back that up, maybe we can lessen the burden for some of these patients. And then personalized care plans. And this is kind of our shtick in the adult world. There's, unfortunately, these personal care plans are not data driven. We use the whole team, and we really just try to be mindful of multiple factors in patients' lives when we're taking care of them. And what I mean by that is, before you prescribe things, assessing their willingness to even do these things. Our patients tend to be very honest. If you ask them before you write 10 scripts for them if they're going to do them and they say no, there's not a lot you're going to do to change their mind at that point. You might just have to revisit it in the future. Feasibility and access issues. I could probably talk a whole hour about feasibility and access issues, but my main point that I want to make is it is still a very expensive disease. As patients get older, we kind of have to start looking at the financial piece a lot differently than when they're kids. We have to start thinking about disability and patients, and when is the right time to get on disability. Can you take care of yourself better on disability? What happens if you're on disability and you get so well that you need to go back to work? What happens then? We have to start thinking about our older patients and Medicare. Medicare covers 80% of medicines, 20% is your own cost. To a lot of people who don't have CF, that might seem like a good deal, but for people who are on things like Pulmozyme or hypertonic, that is not that good of a deal. It takes extra time out of a CF patient's life to have to go apply for programs when they have Medicare to help funding of medicines that they can't cover. And then we always talk about the working CF patient, who oftentimes can be one of the most challenging in the fact that they might make a good amount of money, but when you're paying $40 to $80 for each copay and you have 20 or so medicines, and we like to give you some more medicines sometimes when you don't feel good, right? And then we like you to get x-ray and whatever and whatever and whatever. By the time that all adds up, some people are working just to pay for all of their medicines, and I don't think that I can stress that enough. Pharma's doing a really good job in helping these patients. There's more programs than ever since I've been in the CF world to help them, but still it's very complex. And with insurance being the way it is today, kind of the plight of a coordinator, and all you coordinators deal with this every day, one medicine has to come from this specialty pharmacy. If the patient's involved in a patient assistance program, it might have to come through another pharmacy. You can have one patient be working with 4 or 5 different pharmacies as it's mandated by the insurance or to get patient assistance. And I can hardly keep up with it. I don't know how patients can keep up with it. I spend an hour on the phone with these people. The patients have to spend an hour on the phone with them as well. So when you think about personalizing care plans, you really have to be mindful of all of these things. Also, disease severity, which again, I think providers like more. I think that we should start thinking about more. Maybe we can take something away, or other options for more, faster times, just some more options. So in conclusion, I went over a lot in a very short amount of time. We considered many of the possible age-related complications. We talked about some of the routine health screens that are needed to prevent these complications. Consider multiple barriers and help problem solve. I can't stress that enough. Problem solving is key, as is education and re-education. Never give up, we say at our center. Multidisciplinary team is ideal, because the care of the adult CF patient is very complicated. So I just wanted to include my references and then a picture of some of our care team. They're in Denver. There's a lot of us now. We started with about 4 of us when I started in 2002, and it has grown to this. So, thank you. I got so excited to talk. I have a lot of time left, so I'll open it up for questions.
Gotta give them the rules.
Oh, the rules.
The rules. Just want to remind you, we do have some time for questions. Limit it to 1 per person. Speak into the microphone and allow the volunteer to clean it between uses.
Excuse me. This was on stage the whole time.
Hi.
You made a quick reference to hemoglobin A1C being problematic with CF. Can you expand on that a little bit?
Oh, no. If I did, I apologize. I think I meant to say that we don't use that as a diagnostic tool to diagnose CFRD, but we still do draw it every year or more just to kind of help guide us, but it's not diagnostic for diagnosis. No problem. Hi, Laura.
Hi, Kathy.
Oh.
Speaking of which, so one of the things I was wondering about during your talk is, now that people are actually being encouraged to exercise, you probably have a couple of different patient groups. The younger people coming up in age who haven't really been exercising for a number of reasons, and then the people who show up to when they're older who have been so sick they haven't exercised. What kind of exercise? How do you encourage it, and what kind of exercise do you recommend, and who on the team does that?
So it would be really great if we had somebody like Karen on the outpatient side, but we do not. But our respiratory therapist does some education with that, but we also work with, on the inpatient side, we work with a physical therapist who will sometimes see patients as an outpatient too, who really works on, and they for sure see them when they're inpatient, working on an exercise plan just really based on the specific patient. I mean, you can have an exercise plan. I think Karen touched on this a lot. You can have an exercise plan for patients who are ultra marathoners, which we have some, or patients who climb 14ers every weekend. But you can also have an exercise plan for somebody who's got an FEV1 of less than 30 that might involve weights, yoga, not as high impact exercises, services, even to patients who were in there in the ICU, doing hand weights and hand pulls. Our physical therapist in the hospital is really integral in doing that. And they really try to assess what the patients like to do and make an exercise plan based on that. At our center, we're not big proponents as exercise is the only way of airway clearance. It certainly does help. It's another tool for the toolbox, but we don't often say that we would like you to have another form of airway clearance as well.
Hi, thank you for that. I'm a social worker at an adult program, and I'm just wondering how your team remarks regarding all of the other doctors that your patients need to see, the endocrinologist, the bone doctor, the pregnancy doctor, how do you tell patients, okay, so now we're going to refer you to 3 more doctors because you have this, this, and this, without giving them even more burden? I mean, I hear a lot, no, I'm not going to have that test done because A, I don't want to know what it is because I don't want to have to go to another doctor.
Right. This is a really good question. And I don't know that I know the answer to that, but I will tell you that our director, Jerry Nick, we fought really hard to get an endocrinologist as part of our team that sees patients at the same time as we see patients in clinic. So it's not a separate copay, it's not a separate appointment, and we found that patients are a lot more likely to follow up with their diabetes when we're not sending them to other places. The endocrinologist also is the one who's interested in bone health, so we kill 2 birds with 1 stone with that. We're really lucky like that. We got a psychologist as part of the grant, so she also sees patients with us and does screening and some therapy during clinic, but she's also available for outside appointments. So we also, and again, our director fought really hard for this. We have ENT there on the same days that we have clinic, and they saved time slots for us. So, I mean, everyone's limited by their resources, and I understand that's hard. If anyone has a solution to how we can, how we can help patients deal better with referrals, I'm happy to hear it as well. I mean, I know this is something centers struggle with. I don't know the answer to it. If there is a way that you can get that as part of your team, I think it works out really well.
Can I just have one more question?
Please.
And a comment.
Hi.
My center in Chicago newly has a pharmacist who rounds with us. And it's been really, really helpful to figuring out drug interactions. I don't know if other centers have this, but that's
a lot of people can speak to that around here. I think that's something that's also coming up more frequently. We do not have a pharmacist on the outpatient side that rounds or that sees patients with us. I think we would love it because I've heard of different models where that pharmacist can help with, the pharmacists in some places even help with authorizations, and then they help with getting medications more quickly, as well as interactions, because I think that the interaction world, we're seeing a lot more interactions now. So we have an inpatient pharmacist who does that on the inpatient side for us. And so when patients are hospitalized, they're very involved in interactions. And then they kind of we can sideline them for some outpatient things. But I've heard pharmacists working actually in the center is very helpful. You guys are lucky to have one.
So my question is about osteoarthritis and pain management. Do you find that is an emerging or a major issue, and how does your center deal with that? I know it's a big topic, but
I think that just As patients are living older, now I could really talk about this one for about an hour or two, but pain management as CF patients are getting older is becoming a huge issue as well, not only with osteoarthritis, but just with a lot of common things. I cannot say that we have hard and fast rules on how to deal with this. It's really provider focused and patient focused. I mean, kind of as a rule, we stay away from narcotics. When we have patients on narcotics, they're typically on a narcotic plan, whether or not, we have suspicion of misuse or not. Everyone is supposed to get one. We're working on this. When patients are in the hospital, we have very specific guidelines for managing post-op pain with IV medications and how long that can last for post-op issues, for lung issues. We don't really have a good answer for that. I mean, you also have to consider the patients and the severity of their disease, and I guess also the goals of their disease management, because if you're looking at transplant, that's definitely something we shy away from, using narcotics in our patients that we're sending for transplant evaluation. But if patients aren't interested in transplant, we've been working a lot more with the palliative care providers. We have one at National Jewish who's been helping us actually even prior to transplant, but for patients who have chronic pain issues, palliative care has actually been very helpful. And even when their lung functions are 60 or 70, to kind of help us focus the goals and what the patients think their goals are versus what their goals should be, and then what we're kind of willing to do. So hopefully that answers your question. Thank you.